Today we are going to discuss some aspects of gastroesophageal reflux disease. Gastroesophageal reflux disease, commonly known as GERD, is the most common digestive disorder. It has been found that in the US, where they have an estimated about 9 million hospital visit or clinic visit because of heartburn and related problems. And they have also estimated that it's a huge industrial, it's actually costs is about $9 billion per year. So one can imagine how much of medical attention is given to GERD. GERD is very common. In fact, it has been estimated that you get one attack of heartburn once a month in 25%, maybe once a week in about 10% of population, and in 5% of population you may have a daily heartburn. So main symptoms are of heartburn and reflux. Reflux means retrograde flow of stomach contents into the throat, and one can also complain of water brash and regurgitation, what we call regurgitation of food and acidic juice from stomach. Apart from heartburn, there is also a possibility that these patients may have respiratory problems like nocturnal asthma or change in the voice due to laryngitis, etc. Commonest thing is heartburn, and usually patients are treated with a course of proton pump inhibitors, and normally you do not require special investigations. But in patients, elderly patients, or in patients where there are some alarm symptoms means when patients complain of some food sticking into the gullet, or difficulty in swallowing the food, or maybe there is a case for coffee ground vomiting, that patient is vomiting blood stained fluid, or patient is complaining of severe chest pain or even some abdominal pain or weight loss, then these patients need investigation. Any patient who presents with GERD, the initial investigation is of course an upper GI endoscopy. By endoscopy, we see the food passage or the food pipe or the gullet, and there we might find esophageal ulceration, and in severe cases there may be some narrowing or what we call stricture of esophagus, which is a complication. And sometimes we also find very late complications. It can be adenocarcinoma of the lower end of esophagus. That's a kind of cancer which develops on Barrett's esophagus in patients with GERD, but which is very, very uncommon. So we do not need to investigate every patient, and after doing endoscopy, it would be found that most of the patients' endoscopy will be normal. Only a fraction, maybe 1/3 to 1/4 of patients will have some endoscopic signs of disease. So 70 to 80% of patients with heartburn will have a normal endoscopy. That's why it has been sometimes called that endoscopy negative reflux disease. Apart from endoscopy, other investigations like esophageal manometry, esophageal pH testing is done. These are only kept for patients who do not respond to usual treatment and is not carried out regularly. These days, sometimes patients may have to continue treatment for months or years, and in certain patients where there is anatomical problems like hiatus hernia, a form of laparoscopic surgery is also contemplated, like Nissen's fundoplication, and in that situation one should do a manometric test before proceeding to surgery. Apart from lifestyle modification, I think main stress of management should be the lifestyle modification. Means obese patients should lose weight, They should avoid certain food like fried food, sour food like fruit juice, then aerated water, fatty food like chocolate, hard drinks, coffee, alcohol, and also smoking. So if some patients do follow this lifestyle modification, at least 50% will get better. Apart from lifestyle modification, we also suggest, apart from food restrictions, we suggest that patients should lose weight and should not go to bed just after dinner, must be after an hour or two, and also they should go for regular physical exercise. So once the lifestyle modification is done, patients will feel better, but they need treatment. Usually they are treated with proton pump inhibitors, omeprazole, pantoprazole, lansoprazole, rabeprazole and esomeprazole. All of them are virtually similar but taken according to the symptoms, and they are sometimes given for a long duration. However, one should try to reduce the dosage and put them on maintenance therapy, which is half the normal dose, which can be taken for a long time. Long-term PPI also has its problems, like it can cause some infection, and also there are some problems with calcium and iron metabolism. Hence, long-term PPI has its problems, and we must consider that patients are advised so that they do not take long-term continuous PPI, and they can take on-demand therapy as and when required. GERD as such though it has a huge volume of patients do suffer from GERD, as such it's not a difficult medical problem and can be managed with lifestyle modification, counseling of patients, and selected patients may require surgery. Thank you.